Hey, ladies. So the question came up in the group this week about treating male incontinence after prostatectomy. And what I have found is that's either pretty simple and straightforward or really hard. I don't know why there doesn't seem to be like a great in between. But I just want to review a couple of things and then we'll go over some treatment strategies and ways to think about what's going on with these guys. So here's the male pelvis and just a reminder of male anatomy in terms of the bladder, the prostate, and the urethra and the pelvic floor. So in terms of the pelvic floor, we see the deep pelvic floor muscles here, layer 3 muscles, and then your layer 1 muscles, your ischiocavernosus, your bulbospongiosus, and your superficial transverse perineal are really going to be the muscles that are going to surround the urethra. And so in terms of leakage, we really want to be focusing on the superficial musculature, not so much the deep musculature. The deep musculature can still be important, but we want to make sure that male clients can activate these superficial muscles. And so the cues are going to be different for male patients. So there was a study done on what verbal cues tend to get the best activation in the layer 1 muscles. And those cues are, imagine pulling the genitals in towards the body. Close the urethra like you're stopping your pee. Imagine yourself walking into cold water and pulling your testicles up and in. Imagine your penis is like a turtle, and the turtle is pulling its head into the shell. So those are the cues that we're trying to use to get activation here. We also know for men that activating the adductors can have some overflow into the layer 1 muscles, and activating hip rotator muscles like obturator internus and strengthening hip rotators is equally as effective as Kegels in reducing post-prostatectomy incontinence. So looking at muscle activation patterns, muscle strength, transverse abdominis, looking to see if there's any diastasis recti. These can all be helpful in terms of your musculoskeletal exam and your musculoskeletal treatment. The other consideration that we want to think about is pressure management. And there are so many men that you'll see that struggle with pressure management. And what they do during their movements is take an inhale and then close their glottis, hold their breath. And so this is kind of classic in like maybe an older gentleman with a weaker core. You see them try to get up from the chair and they're like, and they like are doing this kind of thing where they're closing their glottis and filling their torso, filling their lungs with air. And why people do that is because it gives them more stability. But it's a dysfunctional movement pattern, especially once you have your prostate out and you've lost that prostate as part of the urethral sphincter mechanism. So any kind of downward pressure from breath is going to make these gentlemen more likely to leak. So one way to keep the stability of the torso but allow better pressure management is to teach people to blow as you go or exhale on exertion. And what that would look like then is I take a breath in, but on an exhale, I'm going to give like a pursed lip exhalation. And what that does, the pursed lip exhalation gives me a little bit of stability and support through my spine, but doesn't have that pressure bearing down on my pelvic floor. So number one, we talked about muscle function and trying to improve muscle function as best as possible through the pelvic region, the layer 1 muscles, the hip musculature, the abdomen. Concept number 2, pressure management. Really looking at movement strategies and breath strategies, and how can we improve co-coordinating breath, pelvic floor, and transverse abdominis in transitional movements. Concept number 3 is going to be your bladder diary. What are these men drinking? What's their schedule of going to the bathroom? How do they go to the bathroom? Do they sit or do they stand? Does that make any difference in their ability to empty? And then looking at bladder irritants. And then lastly, you want to consider, what type of incontinence is this person having? Is it stress incontinence? Is it urgency and urge incontinence, frequency? Or is it this kind of passive incontinence? And I want to talk about that for a minute. So try to get my urethra out here. So here we have the bladder, and here's your prostate and urethra. The internal urethral sphincter is at the level of the bottom of the bladder where the urethra meets the bladder. And so when the prostate is surgically removed, the prostatic urethra, the part of the urethra that goes through the prostate, is also removed. And sometimes that will cause some damage to the internal or intrinsic urethral sphincter. Why this is important is because that muscle is not under voluntary control. It's an involuntary muscle. And if we lose that, we're going to be much more likely to leak without a real pattern. Like I'm just sitting in the chair watching a show and I'm leaking. Or, I'm walking, I'm fine, and then all of a sudden my bladder decides to leak. Those situations are more difficult to treat in physical therapy because this has been an area of the body that has lost its function. And it's hard to compensate when you lose your internal urethral sphincter. So if someone has that level of incontinence, I'll often recommend a clamp, like the Weisner clamp, Weisner. And if you need a little bit more information about that, you can find it on Amazon. And I also have a handout for using clamps for men post prostatectomy with incontinence. It's actually a really nice idea sometimes to just give the urethra a little compression so men aren't leaking as much. Also can help retrain the bladder if the person is going very frequently and has a small irritable bladder. The Weisner clamp will help them not leak in between voids so they can fill up their bladder a little bit bigger, a little bit with more volume. So let's just review the things that we talked about. Number 1, evaluating muscle and being able to teach activation of layer 1 muscles. Remember that your palpation for the external muscles is external, right? And you're looking for the ischiopubic rami to find ischiocavernosus. You're going between the testicles and the base of the penis for the bulbocavernosus, and then superficial transverse perineal is across from the perineal body. The terms that we're using to try to help men find these muscles are stop the flow of urine, pull the genitals closer to the body. Imagine you're walking into cold water and your testicles are lifting up. Pull the penis into your body like a turtle. I think I already said stop the flow of urine. Second concept, oh, and then also with the muscles, using hip adductors, hip external rotators, transverse abdominis. Second concept is pressure management, looking at this relationship between breath, muscle activity, and movement, and cleaning up any dysfunctional patterns that you see. Third concept, bladder diary. We always got to look at a bladder diary. That helps us identify patterns and bad habits and clean up anything you see in the bladder diary. Lastly, remember that people have different types of incontinence. And if what you're seeing seems like it doesn't fit in stress incontinence or urge incontinence, or urgency frequency, there might be more of a passive incontinence that may be related to that internal urethral sphincter damage. And this is harder to rehabilitate, so this person might do better with a clamp. And don't throw them out, don't discharge them, do all the things. But if they're not getting better, they might have a little bit more a long-term risk with incontinence and have to manage that a little bit differently. Thanks, guys.